Hello, my name's Miles Kiernan. I'm a consultant ophthalmologist and oculoplastic surgeon at North Middlesex University Hospital in London, the UK. I present here the case of a 63-year-old woman who was seen in the oculoplastic clinic with a 10-year history of worsening forehead weakness and droopy eyebrows and upper eyelids that were affecting her field of vision. Of note, her mother and brother suffered the same symptoms. On examination, she had bilateral brow ptosis, bilateral dermatocalasis, and cutis laxa. She had marked weakness of the muscles supplied by the temporal branches of the facial nerve, and to a lesser extent, weakness of those supplied by the zygomatic branches. The remaining branches of the facial nerve were relatively spared. Sensation to the skin supplied by the ophthalmic branch of the trigeminal nerve was reduced, with sparing of the maxillary and mandibular branches.
Smile for me as wide as you can. Show me your teeth. Puff your cheeks out. Okay, squeeze your eyes tight as you can. And then raise your eyebrows as much as you can. Open your eyes and then raise your eyebrows.
I literally can't.
Give it a go.
I'm trying.
Oh, you're trying? Okay.
I'm really trying.
Mild type 2 lattice corneal dystrophy was noted bilaterally on slit lamp examination. The patient's clinical signs and family history were consistent with the diagnosis of hereditary gelsolin amyloidosis, and previous genetic testing had confirmed a mutation in the gelsolin gene. Conservative bilateral direct brow lift and upper eyelid blepharoplasty was performed with a marked improvement in the patient's symptoms. Hereditary gelsolin amyloidosis was first described in Finland, where there are approximately 1,000 carriers. The most common manifestations are ophthalmological with corneal lattice dystrophy, dermatological with cutis laxa, and neurological with cranial and peripheral neuropathy. Facial nerve involvement has a unique presentation. It is progressive, bilateral, and starts with the temporal branches descending to the other branches of the facial nerve over time. Severity ranges from mild involutional changes to complete facial paralysis. Importantly, patients should be counselled appropriately regarding oculoplastic facial surgery. Improved visual function must be balanced against progressive facial and trigeminal neuropathy, and ultimately corneal protection in the long term.